Good afternoon. I am David Chaliantano. I have had the pleasure of being the chair of the Department of Epi since 2008, when John Samet moved on to the West Coast. And it is wonderful to see so many of you here. And when I saw the list of people who signed up, it was like, wow, there are some real great surprises in there. So we're celebrating our 100th birthday. The first class started in whatever century that was, a long time ago, 1918. I'm really honored to welcome you here on behalf of my predecessors. So let's just think who they are. Wade Hampton Frost, Ken Maxey, Phil Sartwell, Abe Lilienfeld, Leon Gordis, Harut Armenian, who is with us, and John Samet. These are the greats in epidemiology. And I must say, I'm very humbled to be associated with these gentlemen. Welcome to the deans of many schools of public health who have traveled to Baltimore to be with us. Our dean will be joining us later, Ellen McKenzie, but I have seen Al Somer here, our former dean, and Mike Clegg had hoped to be here, but I'm not sure he's going to be able to make it. Welcome to the chairs of departments of epidemiology from around the country, as far as Seattle to as close as West Baltimore. So we welcome our alumni, faculty, students, and staff, and many of our friends of epidemiology who are here with us today in Somer Hall, and some who are online. At Hopkins, each department every 7 or 8 years goes through a review. And we last had a review in 2014. And after the school review, Dean Mike Clegg asked 3 eminent epidemiologists to come visit the department for a couple of days and give their evaluation about the status of the department. And those eminent experts were Graham Kolditz, who's here with us today. Thank you, Graham. He's chief of the Division of Public Health Sciences in the Department of Surgery at WashU. Also on that team was Sandro Goulet, who was then chair of Epi at Columbia, now dean of the BU School of Public Health. And the third member was Michelle Williams, who was chair of Epi at Harvard and is now the dean. Pretty impressive. If I get asked to go do a review somewhere, I'll go. But the take-home message of their report, and I should see if Graham remembers. This was in 2015. Let me quote them. It says, "We think that this department should expect more of itself. It should be and can be a thought leader, helping the rest of us anticipate directions in the field, helping shape broader currents of scholarship, and strategically nudging us towards consequential areas that can elevate epidemiology as a discipline, guided in part by a great department in a legendary school of public health." That was full frontal. Graham and Sandro and Michelle, we heard you. We paid attention to your challenge, and hopefully we thoughtfully reflected on our shared vision for the department. And this symposium is in part a response to that challenge. As a group, we're going to review the accomplishments of our discipline, but more importantly, look forward. Look to see where we may be in the future. Keeping in mind the mantra of our school, which is protecting health, saving lives, millions at a time. You know, as one grows older, birthdays become a bit different. We tend not to be excited about the passage of another year, but use it more as a moment of introspection and looking forward. And that's really why we've asked you to join us as a discipline to review where we've been and then think about where's this field going. So on behalf of my deputy chairs, Shruti Mehta and Elizabeth Platts, I thank all of you for participating with us. We look forward to a thoughtful and provocative time in the next day and a half. And at this point, I will stop and let me now introduce Brian Lau. He's an associate professor of epidemiology who organized our Centennial Symposium with Priya Duggal and Stefan Earhart, who are also associate professors here. Brian, Priya, Stefan, thank you so much for your leadership in this endeavor, and we really appreciate all the hard work.
Okay, thank you very much for that introduction, David. And so this is sort of my opening remarks to help set the tone of what we're going to hear about in this symposium. So as David said, it's kind of like birthdays and whatnot. So we could ask ourselves when we were starting to plan this, what are we all doing here? What are we going to do here over this time in symposium? It's 100 years of the Department of Epidemiology at Johns Hopkins Bloomberg School of Public Health. And so, it is like a birthday. Maybe it is like, almost turning 1 year old. Probably not, right? Our department's probably a little bit more mature. We're not just learning to walk, learning to figure out the world so much. Maybe it's like turning 21, right? We're in the heyday. And maybe we should say we could party like it's 1999. But, perhaps we're still a little bit more mature than that. Maybe it's somewhere in our 30s to middle age. And so, I'm probably somewhere in that range. And so maybe I'm thinking about this a little bit in terms of that. But, our department has grown quite large. We're essentially over 100 faculty. We work on a wide range of different diseases, right? And so this 100 years is a time to essentially reflect and in terms of what's happened in the past and to where we're going in the future. So if you think about it in that way, right, we're all really busy. The news cycle is going 24/7 nowadays. You guys have your research, your endeavors, your grants to write, your papers to write. The students are learning, constantly being bombarded. And we don't really have that time to reflect about the field as a whole, as in a broad range of things. So this is the time to do that. So 100 years. Epidemiology has shifted quite a bit over that 100 years. Right? In modern epidemiology, we now study from population levels all the way down to cellular levels, right, in terms of DNA. And we can even go further now with the microbiome and epigenetics, right? So now we have a much different field than we did 100 years ago. Furthermore, we're now at a point where taking cohort studies and other study designs and starting to piece them together to make collaborative study designs so we can try to address bigger and bigger questions. But now we also have the idea of big data, right? Big data has been hyped for a long time, and it's growing, and it keeps on growing, and keeps on growing. And in terms of genetics and everything like that, we've already been dealing with big data. But at some point, we have to also stop and say, not get too overwhelmed by the data in terms of being kids in a candy store, and think about what is it that we can do with this data to have good science. So the goals of the symposium, as I see it, is really to reflect on what epidemiology has contributed to public health and what it will continue to contribute. How are we as a field perceived by others? How are we communicating what the field of epidemiology is about? And what does the skills in which we are teaching actually say about our field? So let's start with that, reflecting a little bit about what is epidemiology for the 21st century. So our standard definition, right? I took it from the Dictionary of Epidemiology from Porta, the 5th edition, the study of occurrence and distribution of health-related states or events in specified populations, including the study of determinants influencing such states and the application of this knowledge to control the health of populations. Okay? And we've been thought of, and I tried to find out where this came from, but we've been called the basic science of public health. Fortunately, I couldn't actually find where that actually terms really originated. But I did find from UNC, and we do have Dr. Till Sturmer from chair of UNC, that offers epidemiology, the basic science of public health. So there's one place where it's been called that. Rothman in Epidemiology and Introduction stated, once considered the core science of public health. Now, recently, in 2003, there is the rise of population health. So Kittig and Stoddard in American Journal of Public Health essentially gave this definition of population health as a concept of health defined as the health outcomes of a group of individuals, including the distribution of such outcomes within the group. And in that paper, they are very much splitting epidemiology away from population health. For some reason, I don't get it. Now, granted, maybe I'm being a little naive, and I don't understand what the difference is here in terms of this definition. But nevertheless, over time, the term population health, if you go onto PubMed, you can see a drastic increase since 2003 where that vertical line is. And recently, Dr. Galea published in JHSPH just recently in 2018, Population Health Science as the Basic Science of Public Health. So now again, taking over this idea of what is this basic science of public health. Interestingly enough, in his consequential paper in 2013, he called it Epidemiology, the Science of Public Health. So somewhere in that time frame, maybe he shifted in terms of his thoughts, but I don't know. Unfortunately, he couldn't be with us today and tomorrow to talk about this. So is population health, is this a rebranding of epidemiology? If so, do we need to really repackage epidemiology into some other term? Is this due to the perception of what our field of epidemiology is? Right? So I have a lot of questions that I'm going to pose in this talk, but I don't have any answers. And hopefully over the next day and a half, essentially, we can discuss and come to some ideas and have some thought-provoking discussions about where we are as a field. Again, Keyes and Galea. So Dr. Keyes will be here tomorrow. Unfortunately, she couldn't be here today, but she will be here tomorrow and talking. But they just actually said, no, population health is a new discipline, population health science. But nevertheless, do we need this sort of rebranding potentially because of the ongoing discussions in our fields? So if you think about it recently, we've been having a lot of discussions about causal inference and other complex methods. So again, in Galea's paper in 2013 in the American Journal of Epidemiology, interest in causes. He starts off talking about that, takes the field away from relevance into obsolescence. In other words, we have shifted too much to just thinking about causes, and that we needed some type of rebalancing. A little bit more critical, recently in International Journal of Epidemiology, it was posited in an editorial that we have focused so much on causal inference using counterfactual reasoning on ever more complex statistical methods that there is little room for working across disciplines. Furthermore, a recent paper by Elizabeth Rogowski and Charles Gray and Charles Poole published this paper in Annals in Epidemiology, an argument for renewed focus on epidemiology for public health. So here they state, much of the work in epidemiology furthers the goals of medicine to identify high-risk populations for medical interventions and to improve patient outcomes. Only a minority of this medically relevant work informs population-level interventions. It produces research that is primarily applied at the individual healthcare level, right? That we are in this area where we're focusing on medicine and not necessarily public health. Now, they did state in this paper, to be fair, they did make a call for both the need for both medical epidemiology as well as what they call public health epidemiology. But they also state, recent attention to personalized medicine has further shifted interest and resources towards medical epidemiology. So that brings us to precision medicine, right? So we have a new challenge in terms of people thinking about precision medicine and what it's going to afford us in terms of clinical medicine and trying to target the right interventions to the right individuals at the right time, right? To also now precision public health. And then this paper by Scott Dow from the Bill and Gates Foundation published a paper in Nature, essentially saying 4 steps to precision public health. And it's probably too small to read this, but essentially when the domestic transmission of Zika virus was confirmed in the United States in July 2016, the entire country was not declared at risk, not even the entire state of Florida. Instead, precise surveillance defined 2 at-risk areas of Miami-Dade County neighborhoods measuring just 2.6 and 3.9 square kilometers, right? So they could essentially focus where their intervention for public health was going to be for the mosquito warnings and travel restrictions. So, of course, you can turn to Twitter for a lot of interesting discussions. So Sandro Galea published a paper, again, in New England Journal of Medicine just recently about public health. And Darren Dolly, who is a statistician, also said the idea of precision or personalized public health is frankly stupid. Sandro Galea are more eloquent here at this paper. Of course, Al Sommer had this spotted 15 years ago. So there you go. But nevertheless, this is the paper that Sandro Galea and his co-authors wrote in New England Journal of Medicine. And then Moon Khoury, who unfortunately also couldn't be here. He was going to attend, but then he had to cancel. He also felt like that this was kind of unfair. The tension between medicine and public health seems unnecessarily spill over to precision medicine and precision public health. It would be a missed opportunity to solve population health problems if we let this tension go too far. And recently, Richard Horton, editor-in-chief of Lancet, published this in their journal, Offline in Defense of Precision Public Health, right? So there's this tension in terms of this. And so the question then comes is, where do we as epidemiologists need to fit in this? So who are we as epidemiologists? Right? We're working at a population level down to cellular levels. There are epidemiology and there are possibly other nascent fields. Are they actually overlapping? So how do we separate ourselves from others? Are we too focused on complex methodology and causes? You know, are we too focused in terms of medical epidemiology and not enough on public health epidemiology? Right? Should we have no involvement with precision medicine and or public health, precision public health? Or should we be involved in either or both? I don't know what the right answer is. And some of this might also come down to how you view we are perceived as a field. So why is this important? I would say this is important for many reasons. As a field, the way we are perceived impacts how the scientific and the public, our scientific and public health results are actually viewed or believed by laypersons, by policymakers, by the wider scientific community. Right? It impacts the field as in terms of how we stay relevant, ultimately. And of course, you know, there's the practical side of things. It also impacts how we can actually obtain funding. So again, from Galea in AJA 2013, he says the risk of marginalizing us as a discipline, right, which then shifted us away in terms of epidemiology and from the NIH strategic plans and the de facto exclusion of epidemiology from several funding opportunities, okay? So the idea that we might be no longer as relevant, and this is going to impact our ability to actually get funding. And actually, I have some anecdotal stories to tell about that. So once I was actually applying for, to establish a biostatistics and epidemiologic methods core for a consortium. And I was talking to the program officer, and they said, yeah, don't call it a biostatistics and epidemiological methods core. Just call it a biostatistics core. Okay. I will take your recommendation and advisement. Of course, I did that, but you know, I was not happy as an epidemiologist, trained epidemiologist. And I was telling a colleague about this, and since I haven't told him that I was going to use this, I did not. I am leaving him anonymous. But he was applying for a grant as well with another colleague, and they were told, yeah, don't use the word cohort. Just say that you're following a group of individuals over time. So, you know, this is concerning, right? I mean, if the perception of our field is such that we can't even mention epidemiology, we can't even mention cohort, then that's problematic. Now, not all institutes are the same. Various institutes have different cultures in terms of NIH. And talking to Elizabeth Platts one time, she says, yeah, epidemiology is viewed great at NCI. There's no problems here. And in other institutes, not so clear cut, right? So there are mixed messages. And then you have things like the director's office at NIH establishing all of us, right? A cohort study. Or ECHO, combining a bunch of pediatric cohort studies together to actually try to create a premier cohort study in terms of children, followed up over time for health outcomes. Right, so how do we think we are perceived? So when we started to plan for this symposium and trying to figure out what we were going to be doing, we did a department survey. We had 127 respondents, and so, you know, it's not the most rigorous sort of questions because we didn't necessarily say pre-test them or anything like that. But anyways, it was just to get a feeling of what the department was thinking and what faculty members were thinking. So we asked them to agree or disagree with the statement, epidemiology is in high regard. And to me, I found this interesting in the fact that we had this distribution. And of the people we were asking who are epidemiologists or affiliated with our department of epidemiology, almost 30% said that they disagree with that statement, either somewhat or very much so. And then another third essentially said they're ambiguous about whether or not epidemiology is in high regard or not, right? And being, you know, somebody who likes numbers, he said, okay, I'll look at something in time since terminal degree, split it up, get some odds ratios, but we all know odds ratios are not the best way to convey things. So what is the proportion disagreeing? It seems to be related to a little bit about where you trained or how long ago you trained, rather. But nevertheless, it's interesting that we think we're not perceived that well as a field. And so, you know, why is that? You know, and it gets to go again to Twitter, because, you know, Twitter is source of all information, right? Quality information. Nevertheless, this is a statistician, I believe a postdoc fellow, maybe, but I'm not quite, I can't quite remember. But Kareem Carr said, statistician, statistical theory and theory, epidemiologist, statistical theory and practice, biostatistician, statistical practice and theory, data scientist, statistical practice and practice. All right? Okay, so then the discussion goes on. Don't think anyone in our biostatistics department who doesn't do applied research. Some of us only do applied research, in fact. And then Ellie Murray, she's a postdoc fellow up at Harvard and a very prolific tweeter, and she has some great tweets in terms of educational tweets and things like that. So if you ever are trying to learn something about causal inference, she's a great resource. But she says, but don't you think there's a difference in applied work biostatisticians do and the applied work that epidemiologists do? Peter Tennant over in the UK said there's a massive difference. P.S. I didn't mean to trigger this interesting discussion about disciplinary differences. She says it's a hot topic. I think there were at least 2 separate conversations ongoing about this in the last week. And he says, in truth, I think they all overlap heavily on the Venn diagram, but there are important differences in how they're perceived in different contexts. And Robert Platt then said, I prefer to think of it as a continuum about how I refer to myself depends on the situation. But I agree, others' perceptions of what the terms mean is perhaps more important. And she asked, what would you say the metric upon the continuum rests? I tend to agree with the continuum, but I'm curious to what you say it's based upon. And it goes on. Slightly different conversation. I wonder if this comes down to a different concern in epi versus trials. Different research questions, different samples, different goals. So he's viewing, you know, epi and trials very differently. L.A. Murray then goes, controversial opinion, but trials are a part of epi. Another person weighs in. I've often wondered about the logic that why would trials be considered part of epidemiology? Well, epidemiology is about understanding the distribution of causes and the prevention of health outcomes. Trials and observational studies are 2 ways of doing that. But by that logic, you can extend the scope of epidemiology to anything relating to disease and health. And you could run a perfectly good trial with no epidemiology input, i.e. a drug trial seems to me to have very little to do with epi. And do you think there's any type of trial that could be considered epi, whether due to topic or design? No, but that seems to limit epi to observational, which I'm not sure is right either. But I also can't come up with the trial context that makes epi input necessary. Ellie says, I'm willing to expand the scope of epi to all things health and medicine, honestly. As I said, distribution of causes and prevention of health outcomes, but I could accept constraining it to as measured to in humans. Okay? So there are ongoing conversations about our field and how we are perceived, not only by people outside our field, but even people within our field. Now, outside our field, we also get into the media and things like that, as well as other things, and not to pick on diet, but the problem with epidemiological studies, right? And they're talking about essentially, there are many different types of studies. Unfortunately, the most common approach used in the field of nutrition is an epidemiologic study is the weakest, least reliable method available. New York Times, government's bad diet advice. An opinion piece in 2015, right? It's long relied on very weak kind of science, epidemiological or observational studies. At best, they can only show association and not causation. Okay? So this is some of the perceptions that our field deals with. Now, it's not all bad news. So Fine et al. In Lancet in 2013 published this perspective piece, Epidemiology, a Science for the People. The tools of epidemiology help us answer the most important applied questions that science can explore. What does good and what does harm in the world around us? These issues extend beyond concerns of researchers and policymakers. Given the importance of epidemiological methods, one might ask whether the subject should now be introduced as an obligatory part of general science curriculum in secondary schools. We think so. Okay? And Nature Communications just this year published this editorial. And we have Dr. Sonia Schmid from Nature Communications who will talk with us tomorrow. And they published this, Epidemiology is a Science of High Importance. I highly recommend reading this for everybody in this room. And so the way we are perceived comes down to the way we are communicating what epidemiology is about. Right? So this paper in JNCI, debate swirls around the science of epidemiology. Goes on to say, many of the articles often written by epidemiologists and other public health practitioners have provocative titles, essentially taking swipes at the methods, direction, role, and purpose of epidemiology. Our chair at the time, Dr. Samet, said, these debates have been going on for decades. Certainly, these questions are fundamental to all scientific disciplines. Epidemiology is not unique. Right? It's healthy to have discourse about what our field is and to take critical look at what we're doing. And the Centennial is a time to do that. It is not only epidemiology's critics whose views its conclusions is second rate. Epidemiologists themselves are unduly self-conscious and skeptical about their own methods. Right? We as epidemiologists are trained to think about what assumptions we are looking at and what we're doing and say there are limitations to what we do. But the question is that might get into our papers. But when we start communicating to outside of our fields, that doesn't necessarily always translate through. So maybe it is about how we describe ourselves. Right? When we are interacting with people at a party or somewhere else, we just say, we introduce ourselves in different ways, maybe according to whether it's a layperson, a public policy maker, other scientists, and the list goes on of whoever you want to think about, right? And so Hillary Robbins, a recent graduate of our department, stated in this tweet, to be honest, I don't identify super strongly with the label epidemiologist. Those of us whose work is wholly unrelated to causal inference get ignored much of the time in discussion of what constitutes epidemiology, in my opinion. And she goes on to later answer, I usually say I'm a cancer researcher, or that I study cancer screening, and give some example about how I do research that informs screening guidelines. I usually only mention epi if the question is about what my field training is in, right? We've all done this. I sometimes go up and say to somebody at a party or wherever and say, yeah, I'm a public health researcher. or maybe I'm an HIV researcher, right? We diminished essentially bringing up what our field is and those opportunities to say what we are and what we're about. So later this afternoon, we will have a session from the Alan Alda Center for Communication Science. Unfortunately, we couldn't actually get Alan Alda, but nevertheless, we will have an excellent talk. By the way, how many of you actually know who Alan Alda is? Okay, good. So I mentioned something in class the other day and about MASH, and people just didn't know. Anyways, so how are we communicating? How do we take it then from what we're going to be shown later today about communication of science from our own individual studies to actually communicating about what the field is? Because it's not only just about what one study is being communicated, because there's themes across it, right? The way we communicate, people start picking up on what the themes are from epi studies across many different press releases, right? So how can we move together to start thinking about what we're portraying as a field? And finally, we're going to have another session about what does the skills in which we are teaching say about our field. Right? We're going to be looking towards what we're doing for the future in terms of epi. What should we be focusing on? Right? Do we need more complex statistical methods? Right? There is value in new and novel statistical methods that we adopt. Right? So Alfredo Moravia, who's also one of our guests here, who you'll hear from in just a few minutes, published this paper, Has Epidemiology Become Infatuated with Methods? A Historical Perspective. And it goes on to say at the very end of this, today's methodological work is much more prominent than it used to be, but epidemiology is definitely better equipped to respond to its public health and healthcare responsibilities than it ever has been. So we can have this talk and this debate about where we need to be in methods and what we're giving up by certain things in terms of what we're teaching, whether it comes to complex statistical methods or down to the basics. Where do we need to be? So what should we be teaching? And what really differentiates us from these other fields? Again, biostatistics, we've all had that long conversation. I'm sure when people applied to the Department of Epis around the world, essentially we ask them quite often, what is the difference between epidemiology and biostatistics? I know we do here. But then we have the field of data science that is now around as well. Where does it overlap with what we're doing, right? What is it, those tech companies in Silicon Valley taking the health data and big data and starting to look at things in terms of prediction or looking at things in terms of mining those medical records? What about population health, as I just mentioned before, where it's being promoted as this new discipline? Where do we have overlap with other fields? Right, so my thoughts in terms of what the theme of this symposium is in terms of thinking about reflection. How did epidemiology arise? Who are we as a field? And who do we need to become? Communication, how do we communicate science better? How do we communicate science about our field? And what is our brand? What are the things that we can actually rally around? And the future, how do we shape our field? Where are we going for the future? What should we be teaching? Because obviously where we're spending our efforts in terms of teaching says something about where we have our values. So with that, I'm going to introduce our next speaker. So thank you, and enjoy the Centennial Symposium that we've put together. So our next speaker is Alfredo Moravia. He is a professor of epidemiology at Columbia. He is well known for his expertise and interest in the historical methods of epidemiology, as well as the editor-in-chief of JHSPH, formerly known as American Journal of Public Health. And so please welcome him.
Thank you very much, Brian. I think your introduction has kind of set the stage to what I want to say, so it may be a nice segue. I want to say also that I'm very pleased to be here today. I've seen, old faces, and they haven't changed, so that's a good sign about being an epidemiologist, I think. And it's also very special for me to be at the same panel with my mentor and Moses Klo, an advisor when I did my training here. I have a very high respect for you. I admire you very much, and your friendship is something I care a lot about. So this being said, 15 minutes to talk about 356 years of history. There are lots of paths, and I could really take you by the hand and lead you through every year of those 356. But there are different patterns that come out, and I thought I would focus on one pattern today, which is the evolution of the epidemiologist. Because I have the impression that there is a misperception, especially among the younger generation, and I think Brian's presentation also reflects that a little bit, that the methods has evolved tremendously over those 350 years. But this doesn't mean that the epidemiologist has evolved the same way, that we were at the Stone Age in the 17th century, and now we're a very smart, mathematically savvy epidemiologist, and we can look down at the people who came before. We're not smarter today, and epidemiologist has evolved, and I think it's important to keep in mind those 350 years of history. So I have my timeline, and as you saw, it goes from 4,000 years ago, because that's when the first urban society, first epidemics occurred, and epidemiology could have been useful then. It goes up to 2062. You see it here. And this idea, the 2062, comes from David Chaliantano, because he told me that then he's going to organize AP 400, which is going to be for the 400th anniversary of the discipline. Yeah, no, I know, he's incredible. But maybe this is a scoop, but he told me that after that symposium, he will step down as chief of epi. So I don't know if I revealed the secret, but anyway. So the first epidemiologist emerges in the 17th century. There is no epidemiology before that. Nature says it goes out to Pericles. Impossible. There is no data before the 17th century. And without data, you cannot discover population thinking. It's totally impossible. What happened in the 17th century, for the first time, we have a substantial amount of data from the bills of mortality. Every week we have data on mortality and from different causes. And this allows John Brown to analyze, 2,500 weekly sheets over 50 years of data. And John Brown, and to create this table. The first table with numbers that we know about, and this is a scan directly from the book. And look at who we think John Grant was. Isn't it great? And he actually was a rich merchant, and only merchants could analyze so much data at a time. And what he saw, no one had seen before. You have here the numbers of over the red line. This is tuberculosis. And what is so is that a disease that at the individual level looked to occur completely randomly, was predictable at the London level. Every year, almost 2,000 cases could be predicted. There were two dimensions. One is the individual. We can't do science there, but at the population level, yes, we can predict, we can compare, and that's what he did for the first time. There is no way you can discover this only by thinking of it. No one before him had come to this conclusion, and none of you here have discovered population thinking, growing up. You've been told, or you looked at data. And that's what happened with Grant. And so there's now been a greater contribution to population science than the contribution of John Grant. Because all the population science we know today, I mean the population-based sciences, in order not to enter in this discussion about public health versus population science, but derive from his work. So that was 350 years ago. And then we have 2 centuries with pioneering epidemiologists. Why are they pioneering? Because they come almost spontaneously to the conclusion that they need to compare groups of people to answer important questions. And they address the most important questions of their time. Of course, in the 18th century, James Lind, who did a detailed review of the literature of his time about the causes and the treatment of scurvy, conducted a small trial. Scurvy was really the main obstacle for the UK to conquer the planet with its navy or defend itself from Europe. And in the 19th century, same thing. You have pioneers in medicine and in public health. And I insist, epidemiology has never been on one domain or the other. Pierre-Louis assessed the effect of the most important treatment of his time, bloodletting, on the most important category of diseases, fevers, inflammation. And the answer was that it didn't work. Semmelweis, he addressed a scourge of modern hospitals. The most modern hospitals suffered from outbreaks of puerperal disease. Nobody understood. He compared groups and he found the difference. And of course, John Snow. He tackled, this new epidemic, cholera, was the main epidemic of the century, the most fearful epidemic of the century. And he actually conducted work that answered this question. So these 18th and 19th century epidemiologists were ambitious, were complex thinkers. They built hypotheses. They designed the instrument to collect their data, collected the data, analyzed their data, wrote books, and they did all this alone. And all of them, and they are the most famous of the epidemiologists ever, because they were such a complex personality and they address such important questions in a very simple way that everyone can understand. Then we move to another species of epidemiologist in the 19th century. This is the public health epidemiologist. And finally, the preferred pronouns can be he, him, his, or she, her, hers, because women enter, in the portrait gallery of epidemiology, not him, but she'll come next. This is Wilhelm Weinberg, a German epidemiologist from Stuttgart, who designed a cohort study of 20,000 children, followed for 20 years in 1900. And apparently he worked alone, and the question was, will tuberculosis wipe out humanity? That was his question. The answer was no, he was right. But his book is a real textbook of epidemiology. It explains everything he did, and you'll find most of the concept we use today. And here is Janet Lynn Clapin. She designed the first case control study of a chronic disorder, because she wanted to know, the question then was, how can we get more women use breastfeeding? And there was this popular knowledge that the trauma on the nipple done by breastfeeding caused breast cancer. And so the question, was there some truth into that? And she designed a case control study to answer this question. And the answer was, as you can imagine, no. And of course, Wade Hampton Frost, the founder of this department. I just want to say that you have to put yourself in the shoes of Wade Hampton Frost. In 1918, he is a public health officer. He's working, to investigate outbreak of infectious disease, mostly intestinal gastroenteritis, etc. And he finds himself with the duty to create a department. And so what is epidemiology? On one side, you have biometry. On the other hand, you have bacteriology, and they have their field. and he have to invent what is going to be the specificity of our discipline. And he's been extremely influential. He's been actually lent to Johns Hopkins for more than 10 years after he was hired as chair. He was from the Public Health Service. But I want to focus on Joe Goldberger, because he's really a remarkable person. When we look in the past and we think, Stone Age, Goldberger here is in officer, uniform of the Public Health Service. In 1914, he emitted a very bold, audacious hypothesis that the new epidemic of pellagra, an unknown disease before in the United States, was due to a deficit in vitamin. And he emitted this alone. Everybody thought this was an infectious disease. And he actually developed field work in South Carolina. And to do this work, he worked with a team. He had God on his side. Oh, sorry, not God, a statistician on his side. And because he was proved right, 2 decades later, he was nominated to get the Nobel Prize. And he should have had it, because the 1929 Nobel Prize was about the vitamin discoverer. And he died a few months before, in January 1929. But if you go to the website of the Nobel Committee, they say it very clearly. And the 2 others were discoverers of other vitamins. He discovered, indeed, vitamin G for Goldberger, or niacin, or vitamin B3, I think. Anyway, so before the Second World War, they were, terrific epidemiologists who addressed very important issues and did fantastic work. In 1950, you have a new type of epidemiologist that appear, and I'll call it the doctor with a hypothesis. And even though their work was important in terms of methods, and if there were no progress in method in the 50s and 60s, the smoking lung cancer controversy would not have been solved. But those epidemiologists, and there are many more, but I've tried to take from different institutions, they are known today for their work, for their research, much more as for than for their theoretical work. But then there is a watershed. In 1976, you have a new species of epidemiologist that appears. This is the methodologist. And the methodologists have a very different perspective. You have to see that the classical epidemiologists typically had their head in vital statistics, in population data, trying to understand what was going on, come out with a hypothesis, and then were designing a painstaking case control or cohort study, which would take years to get their answer. All of a sudden, you have the methodologist who has a very different perspective. This is Olli Miettinen looking at his blackboard, and what he sees is something like that. And this is also a very ambitious attempt, to reduce all epidemiologic concepts to 2 variables, population and time, was brilliant. There's absolutely no doubt about that. Even if the user manual was not user-friendly at the beginning, it became very user-friendly, and it transformed the discipline in terms of methods. But I want to stress here one thing, is that more mathematical and more theoretical epidemiology tends also to be more limited in its scopes, in its concept, in its questions. And there is a tendency for the methodologists to try to also define not only the method, which is very important, and as I said, in the quote that I had, it's extremely important for the discipline. We all need them. That's why they are so prominent in our discipline. But the problem is when they try to go from the methods to the scope and the ambition of the discipline. So when modern epidemiology says, the ultimate goal of most epidemiologic research is the elaboration of causes that can explain patterns of disease occurrence. The ultimate, I think the 300 years before tells you, no, the ultimate is to make a change in health, in justice, in the kind of society in which we live. The ultimate goal is certainly not the elaboration of cause for all the people who preceded that. Or when they ask, should the mission of epidemiology include the eradication of poverty? I believe that if I had a choir from most of the epidemiologists that came before, they would all sing, yes, we can, and I'm sure many people here would also say that's exactly what we are after. But for the methodologists, it's just too far away. It goes beyond their models. So it's more complex than what I'm saying here. But what I try, and my main message is that we should not limit our perspective on the history of our discipline to the last 50 years. There is a lot to learn from the other 300 years. So here we go to 2062. And so David will be here, and he's going to ask us, hey, what species of epidemiologists have we evolved into? And the little e, it's because already 40% of our discipline are women, and I expect them to be even more than, and that's a French trick just to say that it's not only men epidemiologists I'm talking about. The gallery expected to be much more diverse than it is today. But, and I want to conclude with this, I think we are going through very difficult times for public health, for here in this country, in the world. I mean, we're all very concerned about it. And I think this situation calls for, bold, visionary, ambitious epidemiologists who can rise to the challenge. And I think these epidemiologists can find inspiration, not only in the last 50 years, but in our last 356 years of existence. Thank you.
Okay, so I'd like to introduce our next speaker. It's our very own Dr. Moises Sklo, who's a professor in our department and has just recently been given the Distinguished Service Professorship Award from the university. He is, been a stalwart of our department, and he has won many awards, including, for those of you who have not heard, but you probably did when he gave his lecture a few weeks ago, the commander of the Brazilian government, which is pretty interesting. I still don't know what it actually means, but I'm curious. But he has been editor-in-chief of the American Journal of Epidemiology for the past 30 years. So please welcome Dr. Moises Sklo.
Can you hear me? Am I audible? Okay, don't think that only people with an accent have been invited to make presentations. So, I don't know exactly how to move this thing here. Oh, okay. So what I want to do is to say something about the, thank you. The AJE, the history of the AJE. And then say something about the contributions that our faculty have made to translational epidemiology, public health, prevention. All right, so let's talk about the AJE. The AJE was founded in 1920 as the American Journal of Hygiene. And in those times, it mainly publishes papers on lab-based research, microbiology, parasitology, virology, and so on. And jumping to 40 years later, because I only have 15 minutes, so it's amazing. More than 40 years later, Mainly, the papers were mainly infectious disease epidemiology and lab-based papers. Now, in 1965, he changed his name to American Journal of Epidemiology. And Neil Nathanson, who was the editor-in-chief, wrote an interesting editorial. I wanted to highlight a couple of things. One of them is that he says that, so far as we are aware, there's no journal in the English language which has the word epidemiology in its title. And then what he said is that the change in title means that the board of editors will welcome an increased number of papers which have significant contributions to the epidemiology of non-infectious diseases. Very interesting. Well, 5 years later, still infectious and lab predominated. But 15 years later, chronic disease epidemiology started to predominate. And of course, these days, as you'll see, we are mainly a chronic disease epidemiology journal, although we do publish quite a few infectious disease epidemiology papers. But Neil Nathanson also wanted to stimulate papers with significant contributions to the epidemiological method. And Alfredo has mentioned some of that. But in the 1970s, we started to get a lot of papers on methods. And this is one of the landmark papers by Olli Miettinen, who used to be a nice guy, but a little bit of a pain in the neck, but great scientist, researcher. And this is one of the major contributions he made, showing that if you use a sample of the whole defined cohort as a control group, when you calculate the odds ratio of exposure, something magical happens, and really what you get is the relative risk. So the case control designs within a defined cohort became very popular. Anyhow, we also started to publish papers on causal inference in the 1970s. So the 1970s are an important decade from the viewpoint of the number of papers on methods and causal inference. Now, these days, as I said, most of the papers we publish, almost 80%, are chronic non-infectious and methods, mainly epidemiological methods. But we do encourage papers on infectious disease as well, of course. Now, I can't make a presentation, it's almost like an addiction, without talking about George Comstock, okay? And the interesting thing about George Comstock is that he developed a series of interesting methods and study designs without publishing those in separate papers. So he actually was a forerunner for many of those methods and strategies, but in terms of the application of those to his research. So I just wanted to point out to you some of those. He may have conducted the first case cohort study. He pioneered with Lilienfeld the use of blood samples in cohort studies for future analysis. He conducted the first cluster randomized study in Alaska, and he showed that case control studies test effectiveness, not efficacy, of interventions, including screening. Now what I want to do, our department, heeding the advice of the review committee, of which Graham Coldis, who is sitting right there, and who used to be an editor of the AJE, and therefore he's a very wise guy. One of the things they recommended is that we encourage the teaching and research on translational epidemiology. So I think it's a good opportunity to review some, and I apologize because a lot of excellent developments are not here, research is not here. So there's just some of the example that of our department's contribution to research relevant to translation epidemiology. Now, of course, David Bodian, we have to mention him in the first place because he laid the groundwork for the development of polio vaccines together with Isabel Morgan and Howard Howe. He discovered the 3 basic immunological poliovirus types. He demonstrated that primates and man can be immunized with formalin treated virus. And he demonstrates, this is crucial, that minimal levels of serum antibody could protect against invasion of the central nervous system. Incredible discoveries. Sartwell. Sartwell was one of the chairs in this department before Abe Lilienfeld, and he really showed that infectious diseases, that point epidemics or infectious diseases have a log normal distribution. And that work was followed up by the work of Arminian and Lilienfeld, very important, showing that point epidemic curves of non-transmissible diseases also follow a log normal distribution. And those authors give examples, bladder tumors in dye-stuffed workers, leukemia after the atom bomb explosion. Now, why is that important? For two reasons. Number one, for confirmation of point epidemics of non-transmissible diseases after the introduction of new agents. But it's also terribly important for translation epidemiology that to show that the understanding of heterogeneity in systematic reviews when studies are done at different times after the introduction of a new exposure, so that if the studies are done before the minimum incubation period has gone by, you don't expect to see an association, only after the minimum incubation period has gone by. So this is an important research. Now, of course, Frank Polk, everybody knows, and his collaborators, pioneers in the study of HIV. He initiated a series of cohort studies, and of those that you see on your right, only K-Marx he's not the PI only for K-Marx. Alfredo Munoz, who is sitting right there. It's really interesting to see so many historical people in this auditorium. Alvaro, who is sitting there, was the PI for that. Otherwise, Frank Polk initiated those studies. But with a lot of collaboration from many, many people, and you can see their pictures here. Now David and his group, Shruti, who is also sitting here. I knew you were coming, so that's why I have your picture. They also did some key studies showing the importance of recognizing and preventing depression in young adults with substance abuse in Thailand. They showed that in the injection drug users, programs for the prevention of sexually transmitted diseases should also include spouses. I think, Shruti, you're the first author of that one. And then they also showed that there was a 14% reduction in HIV incidence using a multi-component, multi-level social and behavioral prevention strategy. John Salmon got the Surgeon General's medallion for his work as senior editor of the report of the Surgeon General on health effects of secondhand smoke. Javier, you also helped with that, didn't you? Yeah. So, but you didn't get the medal. How come? All right, there must be a reason. And going to Joe Koresh, he developed a new equation with his group to estimate glomerular filtration rate. This is very important for epidemiological studies of chronic kidney disease. And other people, I don't think they were, maybe all will tell me differently, but I don't think they were epi faculty at the time that they made those important contributions. But eventually, either before or after, they were epi faculty. Alex Langmuir, who established the CDC Epidemic Intelligence Service. D.A. Henderson, of course, the smallpox eradication. Al Sommer, who is sitting there, discovered that vitamin A reduces mortality in children. And Morton Levin, who developed the idea of population, unadjusted population attributable risk. And things continue. I mean, our contribution, the department's contributions to translation epidemiology continue. Those are just some of the examples. Lorraine Dean, who is interested in social epidemiology. Larry Apple from the Welch Center doing the vitamin D in false randomized clinical trial, the study. Carlos Castillo, who is the leader of the Global Public Health Observatory. And then Frank Lin, Richie Sharrett, and Jennifer Buell, who are involved in a randomized clinical trial of hearing loss and dementia. All right, let me finish just describing some of my hopes for the future of epidemiology. And it's just to generate discussion, okay? So those are my biases. Number one, I would say I hope there will be increasing recognition of the importance of translational epidemiology in implementation science, and also that the semantics of applied translation epidemiology is not entirely consistent with that of etiological epidemiology. I think this is important, and the department actually has a committee who is studying and making recommendations for teaching and research on translation epidemiology. They have prepared a report, and that has been submitted to the AJE, to the American Journal of Epidemiology. Now, this is interesting. This is my hope. I don't think it's going to happen. More flexibility from funding agencies, given the transdisciplinary nature of epidemiology. What do I mean? Well, let's go back to Snow on cholera. Look at all the things he's done. Spatial studies, plotting cases around the Broad Street pump, self-experiments. He actually got close to the cholera patients. He washed his hands, and nothing happened to him. So he disproved the miasma theory. He also did etiological studies on sources of water and analytical epidemiology. So he went back from the lab to the population and so on. And this is important. Growing reliance on randomized trials to evaluate prevention and cessation of risk factor exposures. That's another hope. Clarification of the current confusion between the epidemiological method and the statistical method. I think there's a lot of confusion these days, and they are both very important, but they are not the same. I think epidemiology is development of a plausible hypothesis, development of a study designed to answer that question, and the conduct of quality assurance and quality control studies. Whereas statistical method, everybody knows what it is, okay? Use of big data with quality assurance and quality control is another hope. Studies based on life course cohorts to better identify early determinants and mediating factors and increase recognition of the role of social determinants. Development of biomarkers to measure present and past exposure. Those things are very ambitious, right? I think eventually they will happen, I hope. Better understanding of the potential of metabolomics and proteinomics. Growing understanding of the potential and limitations of new analytical methods. Instrumental variables, Mendelian randomization, and the use of observational designs that mimic randomized trials. And last but not least, increase epidemiology students' exposure to human biology and primary data collection. And that's it. Thank you.
So our next speaker is Dr. Karen Thomas. Hold on, let me just put that one. And so, Dr. Karen Thomas is our school historian at the Johns Hopkins Bloomberg School of Public Health. Her focus is on the history of medicine and public health, has received national awards from the American Association of History of Medicine and the Southern Historical Association. And she is an author of a book called Health and Humanity, A History of Johns Hopkins Bloomberg School of Public Health, 1935 to 1985. So please welcome Dr. Karen Thomas.
Good afternoon. It's such a pleasure to be here. I am a non-epidemiologist talking to a group of epidemiologists, so I hope you'll allow me to be an interloper. I'm going to start by saying that all of the great epidemiologists and the founding dean of the school, William Henry Welch, believed that the history of public health was a really essential field, and they actually wanted to require it for graduation from the school, and I would like that too. So history is extremely important, and I hope we're seeing that today. So I'm going to cover some things that have already been covered, but I hope they'll have a unique insight. We can't talk about epidemiology at Johns Hopkins without beginning with the first chair of epidemiology in the United States, Wade Hampton Frost. I'm going to pause and say Wade Hampton Frost's ideas and work helped to save millions of people's lives ultimately, and I admire him tremendously. But he is named for someone who is a quite terrible person. Wade Hampton, if you know your Southern history, he was a politician in South Carolina who helped bring back white supremacy after Reconstruction. So it's very ironic to me that someone who is so good and has done so much for us is named after someone like that. So that's an observation. But he came to the school and came into public health at an extremely energizing time when public health was really still brand new. The Marine Hospital Service had just been reorganized as the modern public health service. The school had just been founded in 1916 with a grant from the Rockefeller Foundation. And in September, right before we're trying to open our first classes at the school, the first really major wave of deaths in the great influenza pandemic is beginning to pick up. So we have a rather inauspicious start, you could say. So Wade Hampton Frost is then working as he's been a public health service officer for several years at this point, and he is called by the Public Health Service to lead the major study of the scope and incidence of influenza mortality during and after the pandemic. And in doing that very practical applied epidemiology, he developed some very important methods and theories that he goes on to teach after he comes to the school. One of which is, at this point, it's very difficult to tell the difference between influenza and pneumonia and other things because not only are there no effective treatments, or very few, there's no antibiotics for several more decades, but there's not even good diagnoses. And so what Frost does is to figure out that the cycles of annual mortality for pneumonia have a baseline, and he creates a method called excess mortality to figure out, these additional cases that spike during these epidemics, that's probably influenza. So he is, it's a brilliant epidemiologist, and very fortunately for us, the reason why our symposium and our centennial is starting in 1919 is because that's the year that William Henry Welch convinces the Public Health Service to let us have Wade Hampton Frost. So Frost collaborated very closely with Lowell Reed. Frost was dean for a couple of years in the early 30s, and then Reed became dean after that. And they are really the dynamic duo of public health research for a good 20 years during this time. And there is a terrific documentary on PBS that just came out recently about eugenics. And if you realize that at this time, so if you look at the poster on the lower right corner there, it says tuberculosis is preventable and curable. That was a very new sentiment at the time. People assumed that death was just, your fate. There was very little you could do about it. So Frost and Reed really convinced us that disease is not destiny. It doesn't have to be. And they convinced us that, and they taught generations of students, the disease can be classified, it can be quantified, it can be surveyed and mapped. In other words, you can study it and you can prevent it. And that was truly revolutionary in a way that I don't think we fully think about very often. But in order to understand the importance of epidemiology, all you have to do is think about what was it like when we didn't have it. And that's basically people thought you were just going to die. I think one of the most influential and important contributions of the school as a whole has been the social epidemiology of the family. So after these various individual people that the previous two panelists talked about were doing their work in their merchants' quarters or whatever they're doing, Reed and Frost really started to look at a much wider social context for epidemiology. And it was here, right in the environs of this school that we're standing in East Baltimore, they began to do house-to-house, block-by-block surveys of disease in the Eastern Health District. And that idea of a neighborhood health district as a laboratory for public health research originated here and is spread around the world by the Rockefeller Foundation and by the graduates and faculty of the school. So, disease is not just something you can map on a physical map. You can look at the relationships among families and contacts and understand how does this disease hit an entire community and the specific connections that have to occur for that to happen. Another really major contribution of the school is that in close collaboration with the Public Health Service, which I think you realize by now is a theme here, that they conduct the first national incidence studies of not only the major communicable, but also the major chronic diseases and mental illness. I know that we have someone who's a specialist in psychiatric epidemiology here today. And we did not fully understand just the basic incidence rates of many major diseases until these studies began to open that information to us. And the U.S. Commission on Chronic Illness, which was a collaboration of a number of different major public health and medical associations, and that was based here at the school in the mid-1950s when this continued. And it gives us how many people are suffering from schizophrenia, how many people are dealing with cancer or other chronic illnesses. So that's incredibly important information, and it comes directly out of this Frost and Reed approach to epidemiology, which is also known as shoe leather epidemiology and becomes the emblem for the Epidemic Intelligence Service. So that serve in the Public Health Service and then come to Hopkins and teach epidemiology model. Frost kind of starts it, and then George Comstock, who's been mentioned earlier, continues it. He's in the Public Health Service during and after the war. He comes here to get a doctorate in public health in the mid-50s. And just as Frost had worked on influenza and then tuberculosis, Comstock follows in his footsteps and does the legendary isoniazid studies in Alaskan Inuits in Bethel, Alaska. And so this is the size of the epidemiology faculty in 1936. There's a total of 8 people. Frost mentors Miriam Braley, who's in the lower corner there, the first woman epidemiologist and the only for a very long time. And she becomes, not only is she on the faculty, but she also heads the division of tuberculosis in the Baltimore City Health Department. So that's another major collaborator for us as our local health department. And she, in the 1940s, at the height of Jim Crow segregation, is looking at, she's a pediatrician, and she looks at racial disparities in TB incidence in children. And she not only documents them, but she provides recommendations for the department to address those, especially increasing funding for tuberculosis hospitals and making sure that there's accommodations for children in them. So I really admire her a great deal, and she is one of Frost's many disciples. So in most of the 20th century, the Department of Epidemiology here is very oriented around the great diseases of the day. And so before World War II, it had been very much focused on tuberculosis. And then Frost, toward the end of his life, recognizes that, wow, TB TB mortality is decreasing, even though the incidence isn't necessarily decreasing. In other words, people aren't dying from it anymore. And he recognizes that there's going to be an epidemiological shift toward chronic disease. So I think he's pretty amazing for recognizing that as early as he did. But by the 1950s, 40s and 50s, of course, polio is in all the newspapers, on all the radio broadcasts, and it's our polio lab up there with Kenneth Maxey is in the lower row in the center. Kenneth Maxey is another disciple of Frost who takes over as chair of the department, and he has the great insight to steal away some polio researchers from the medical school. A young guy named David Bodian and his mentor at the School of Medicine, Howard Howe, and he brings them over to epidemiology. And I think this reflects some of our questions about, well, what is epidemiology and how much does it relate to laboratory science and how much does it relate to biostatistics? But we had this triple strength at the school in biostatistics, laboratory science, and epidemiology that all informed and reinforced one another. And that was never so true as in the polio research, where we really, I would say, adjudicate. We help to decide, Maxey, David Bodian, and Thomas Turner, who later becomes dean of the medical school here, they are on the top committee, the vaccine development committee at the National Foundation for Infantile Paralysis, that decides, can we give this vaccine we've been cooking up, can we give that to kids and expect that they won't get paralyzed from it, which had happened during a previous vaccine trial. So that ability to not only develop but also to evaluate vaccines, that becomes the foundation for, it's still with us today. The techniques and the tissue culture techniques that George Guy developed were also used on the polio vaccine. All of those things come out of lab science and the polio work, and they set the stage for everything we do in vaccine development after that. And before I leave the polio, Frost and Reed, they were well known within public health circles, but David Bodian was a rock star. He made the pages of Time magazine regularly, and people, who knew very little about research or public health, they knew who he was. And it's polio that really puts the school on the map in the national consciousness. And different diseases continue to do that periodically, and we're about to see that. So as polio is kind of waning in intensity as vaccination picks up, we become involved, as Moises has already noted, in looking at the role of cigarette smoking on lung cancer. And this is the early version of big data, right in the center of the screen. That is an IBM punch card and some data tapes from about 1980. So it's in the 50s that we get the ability to do much larger cohort studies and instead of doing trials or cohort studies on a few hundred people, we'd start to do them on thousands of people. And cancer and cardiovascular disease, as of course chronic disease becomes the main killer in the United States, they dominate the department, the funding, the structure, the teaching of the department. And but one thing that no one else has mentioned, so even though I'm not an epidemiologist, at least I know this, environmental causes of cancer and disease they come into play, and Genevieve Matanovsky, who we're going to hear from later, is among the first to recognize that cancer is caused by toxic exposure, and does the hard scientific research to prove that. By 1981, when Abe Lilienfeld is editing the first edition of reviews in cancer epidemiology, he says, it's environmental factors that are really the primary drivers of cancer incidence. And finally, we get to AIDS. And so as we've seen, we've gone through tuberculosis, influenza, tuberculosis, polio, cancer, cardiovascular disease. So the department has very much been driven by these different diseases. And then, and we think that chronic disease is our main concern and infectious disease is on its way out, and we don't really have to worry about it too much anymore. And our infectious disease division had shrunk to almost nothing by 1980. And in fact, I looked at the departmental report, and in 1981, there was one publication of the faculty among 100 or so, one on infectious disease. It was on rheumatic fever, I believe. No, I'm sorry, that's wrong. It's not. Anyway, it's striking how small an emphasis there was on infectious disease. And then, of course, AIDS changes all of that. So AIDS, like polio, again brings the department and the school onto the national scene, and as we've already talked about, the MAX study generates these incredibly important insights into the key risk factors, and not only the biological, but now we're really getting into the importance of behavioral and social science, and that's definitely David Chaliantano's background as the first chair of epidemiology who is not an MD and is a specialist in social and behavioral science. So that's a major departure from the history of the department. So these are, I would say, the greatest hits, and I'll stop there. But so your department is now, the bench is so deep and the scope is so broad compared to these earlier years and throughout most of the 20th century when we went from one big disease to another. Now we study all of the diseases, all of the factors in health and disease. And so I think that's your future. You're going to be a much more interdisciplinary and broad department. And I look forward to seeing what that's going to be in the next century. Thank you.
So this is just to say that we're going to conclude this session because in the interest of time, and we have a half-hour break, and then we are going to premiere the documentary that we have filmed and put together for the symposium, starting at 2:30. Thank you very much.